So what we're going to talk about tonight is paediatric assessment. And paediatric children are one of those topics or one of those jobs no one ever wants to go to. Why that is, I don't know. There's barriers. As long as we understand how to assess children properly, then we shouldn't be scared of these jobs. So what we're going to talk about are the kind of key things that we need to remember. We're going to talk about some frameworks that will help you assess a child. And then finally, we'll talk about just 2 common or 3 common conditions that you may come across, especially coming into the winter months. So what we're going to do, we're going to go on and talk about our trust behaviours. So during the session, learners agreement, we talk about every single session we cover. So we're going to be caring, compassionate, we're going to ask and listen. We're in a educational learning environment. We're going to be open and honest. If you ask me a question, I'm going to give you the most honest answers I can. We're better together and we're going to own our own decisions. It's not the kids, it's the parents. Exactly. Yeah, we'll talk about parents in a short while. So the aims of any CPD that we do and that we offer you is to increase your confidence in your clinical scope of practice, but also your self-confidence to discharge duties on behalf of the Welsh Ambulance Service. So tonight, we're going to, an hour-ish, we're going to talk about how to formulate a primary assessment using the CABCDE approach and how that changes slightly with paediatrics and some considerations we need to take into account. Then we're going to talk about some differences between adults and children. We're going to talk about those frameworks. So we're going to talk about the paediatric assessment triangle. We're going to talk about POP scoring and some of the parameter changes. And then finally, like I said, we're going to go over some common paediatric emergencies that you may come across. Everything we're covering is out of the first responder care essential, which isn't a lot in paediatrics, but most of our guidelines in the pre-hospital environment come from the JR Calc. So let's start off then. Primary survey. In the chat box, how does the paediatric primary survey differ to an adult primary survey? Or what considerations do we need to think about when we're kind of assessing the primary survey on a child? And remember, paediatrics covers 0 to up to the age of puberty. So we could be thinking of a baby, we could be thinking of a toddler or an older child. So yeah, Louise is coming there with the age. So yeah, like I said, paediatrics is a very wide range. The look of the patient, good. And a lot that you guys are going to do is about looking at the patient. We're going back to the basics. Observations are okay, but they're not great with the children. We do a lot more from just standing back and looking at the child. So going back to basics is really important. How the parents are responding, good. So please never dismiss parents. They know their children. They know when their child is unwell. So normally, if the parent is panicking, then something isn't right. The colour sounds good. We're going back to those basics. Communication can be a big issue with paediatrics and their development stage. Again, if mum or dad are concerned, a quiet child isn't good. They are not small adults. Yeah, good. And we're going to talk about the main things coming up. Different ranges of observations. Yeah, very good. Excellent. Okay, cool. So we've got quite a lot of them. So we're going to break down and talk about the primary survey. So what we know about the primary survey is it is a rapid assessment. In adult patients, we're looking for the most critical condition that is going to kill the person sooner. So catastrophic hemorrhage, we're going to fix. Airway problems, we're going to fix before going on. So it's that stepwise approach, and none of this changes for a child. It's slightly amended for medical versus trauma, because hopefully you won't come across a child with a catastrophic hemorrhage. That's really, hopefully, really unlikely, but it is possible. It allows you to form a general impression. and it's also known as the end of bed assessment, especially in hospitals. So that general impression again is really important, and it differs from an adult to a child. So hopefully you all can walk into a patient's house and recognise a sick adult, because their positioning, they could be tripoding, they could just be flat. We can look at the colour of them. If they are grey, if they're clammy, we can instantly find out if someone is poorly or if they don't look too bad. So they look systematically well or systematically unwell. And in adults, that's really kind of easy to note, and hopefully you'll be able to walk in and see someone who is having a massive MI, or someone who is massively dehydrated compared to someone who's fit and well, who's just opened the door and welcomed you in. So that's kind of the primary survey. It is the same process as a child, but we're going to talk about some of the differences. The biggest one there is the cognitive kind of development of the child. In adults, we can ask questions. Depending on the age of the child is depending on how much information you're going to get back. So spotting a sick child can be really difficult. So what we're going to do is go through that doctor's CABCDE approach, and we'll talk about some of the considerations that we need to consider. So primary survey doesn't change. It's still going to be the same as our form. We're going to do our danger response. Dangers don't change if you're going to a child or an adult, so your safety is the priority. So please make sure you're going into a safe environment. Checking for response, we're still going to do our AVPU. So we're still going to see if the child is alert, if they're responding to the voice, responding to pain, or if they're not unresponsive or they are unresponsive. Catastrophic hemorrhage, again, nothing will change. We need to recognise a significantly bleed that is going to kill that patient. When we go into circulation, we'll talk about blood volume, and that shows how important catastrophic hemorrhage control is when we talk about how little blood they have from newborn and up. Airway then. So airway is the biggest thing that we need to talk about, really, because that is what is going to kill your child sooner, is your airway and breathing problems, those A-B problems. C problems are a little bit less common. They do happen, but A and B problems are the big thing. So we're going to talk about them a little bit more in depth, but when we're talking about airway, we're looking for those common problems. And the three things that we're going to hopefully notice is secretions from that child. So from a young age, if they've got a lot of secretions, then that can lead to an airway problem, especially in infants. We're looking for stridor, and hopefully we all know what stridor is, and we're going to look at some videos a little bit later that will demonstrate, and so we can hear what stridor is. So it's that upper airway restriction, that high pitch kind of squeaking noise. Again, in children, different age groups, we've got a little bit more concern that we'll talk about. And then finally, foreign bodies is a big one. Children likes texture. They are learning by feeling and tasting. So anything they get, they instantly just put in their mouth. So choking on foreign bodies is a big thing when we're talking about airway. Remember, this is primary survey. So this is quick things that we're looking for. Quickly, we're looking for secretions. We're looking for stridor. We're looking for foreign bodies. If we've got secretions, we need to get them on their side so they've got that natural drainage. Foreign body, we're going to go down our choking protocol. So they're the big quick things that we need to look for when we're talking about the primary survey. Breathing then, so hypoxia. Again, this is the most common cause for a cardiac arrest in a paediatric. It's down to a hypoxic respiratory arrest. So again, really important that we identify any breathing problems really early on in this initial primary survey stage. So what we're looking for is the respiratory rate. Respiratory rate is so important in children. It is one of the first signs that we can notice when a child is sick. If we're talking about meningitis, we're talking about any massive infection, the respiratory rate is going to go up. Patient's going to try and compensate. So please really remember, important thing is to take a respiratory rate and count for the full 60 seconds. Other things we're going to look for are recession and the use of accessory muscles. Again, that changes with the different age groups that you may come across, but we've got some videos a little bit later that will demonstrate the use of accessory muscles in infants and in toddlers and a little bit older. So again, really important that we recognise that early in this primary survey stage. Then we're going down to circulation, and some of you mentioned this, is the colour of the patient really important. So we're looking for if the patient is pale and if your patient is mottled skin. So mottled skin is that marble-like kind of kitchen surface top just to their skin. So colour is really important, and asking the patient or the parent or carers, is the child pale? If it is, then that's a big red kind of flag marker for us. Then we've got our heart rate and pulse rate, and again, it can be quite hard to find a pulse rate in a child, especially when we talk about radial. You may have to go up to the brachial to get a good pulse rate or a heart rate. If you can't, it's not a big problem, because we can always default to a capillary bed refill, a CAP refill. So we're going to talk about it a little bit later, but centrally is good. And again, in this primary survey, we should be checking the temperature of the child. So don't need a thermometer, we're just going to feel. We're looking at the hands and the feet. If the hands and feet are colder than the core, then that is another red flag for us, because the body is trying to protect itself. It is peripherally shutting down, bringing all its blood into its vital organs. So again, it's really important that we identify if for temperature, just for touch. We're going down to disability. Same checks as an adult. We're still going to do our AVPU. We're still going to do our Glasgow Coma scale. We can look at limb tone as well. If they're moving all limbs, have they got actual tone in their limbs when we move them? Are they just floppy, or are they resistant to you? So that's falls under the disability side. And then finally, exposure. And we talked about temperature, keeping your child warm, and doing your top to toe survey. You can't do a primary survey without stripping that child down to their nappy, because you're not going to identify any breathing issues or any circulatory issues, because you're not going to be able to look at respiratory muscles. You're not going to be able to see if that patient's pale or mottled skin. You're not going to be able to feel their temperature correctly, and you're not going to be able to identify any kind of that secondary top to toe survey, any rashes or anything major. So any infant, we need to strip them down to their nappy so we can do a primary survey correctly. So that is the primary survey. Other big thing that we need to note and consider that we don't really do with adults is safeguarding. So safeguarding is a big issue with children, especially in the recent news that we've had. Really sad that it can happen, but we need to identify any safeguarding concerns. So if you've got a gut feeling this doesn't feel right, why is this child like this? Why is this child injured? You're looking at the environment, then we need to consider any safeguarding concerns that you may have at an early stage. So that is our primary survey. We're going to talk about a little bit later. So Ben's come in with the Safeguarding Wales app is really useful. So Ben's coming in, child's, I'm guessing it's much narrower. Yeah, cool, we're going to talk about that. Less robust in the child. Child's airway is floppier. So yeah, children are developing, they are growing. What have we got? Flatten if head tilt back. Yeah, so we're going to talk about the big old part in the head, and we'll talk about that natural alignment as well. Thin and soft. The size of the lung and the volume of the lung, good. We'll talk about that in our breathing section. They could have an object in their airway. Yeah, good. So we're talking about those foreign objects. They like to taste and feel textures. You don't do a full head tilt chin lift. Yeah, good. So we're talking about that natural alignment. So with children, they've got a big back bit of their head. So if they're lying naturally, they'll just close their airway. So sometimes we just need to put some under their shoulders to have that natural alignment. Good. Soft tissues, yeah. Soft palate, the nose. Excellent. So yeah, I think we've got quite a lot there. So let's talk about some of them. So smaller face is a big one. So our child is going to have a smaller face. And why that is important, we're going to kind of go on to, and the development of the face as well. So they've got a smaller face. They've got their compressible kind of floor of their mouth. So smaller face, and so this is really important when we're talking about mask sizing. So I know we've only got the one pediatric BVM. So it's really, again, really important that we size that correctly. So it's got a smaller face. What we don't want is the mask to go over their eyes, and we'll talk about why that's important. What we also need to do is consider this soft palate, this floor of the mouth isn't developed correctly. So as adults, you can feel it and you can push under and you can feel your kind of structures. With a child, it's still developing. Like you've all said, everything is soft. So if we're going to push and we're going to do a jaw thrust or we're doing a head tilt chin lift, we can actually close the airway by just pushing in underneath. So really important that we consider where our hand positioning is as well. What we also need to consider is reflex bradycardia. So what reflex bradycardia is if we've got a mask that is too big for the child's face and it's going over the eyes, all we're going to do when we're inflating is put pressure on those eye sockets. If we put pressure on the eye sockets, that in turn will put pressure on the vagal nerve. And the vagal nerve will slow everything down and it will slow the heart rate down. So really important that we've got the correct sizing and we're not going over the eyes. So if it is too small, all you need to do is turn the mask around. So you've got the pointy bit down here. So you've got the flat bit there, pointy bit down there. So if you are going to lose pressure, it's going to go down under the chin and it's not going to go onto the eyes. So we wouldn't have that risk of the reflex bradycardia in children. So yeah, therefore the mask is really important. Obstructions in the airway is the most common cause of death that we have talked about previously. So we've talked about having a narrower trachea and a shorter trachea. So in a child's windpipe, it is shorter and narrower. So more common for it to be obstructed. And unlike a child or unlike an adult, when we have got a choking patient, we've tried our back slaps, we've tried our abdominal thrusts, it's not working. The patient goes unresponsive. Then what we try and do is a forceful ventilation to push the object down into one of the bronchi. So at least they've got one lung working and they haven't. And that's what we do in adults. This does not work in a child. So it's not able to clear and go down into the right lung. So because it being so narrow and short. So again, really important that we consider airway obstructions and hope the choking protocol works correctly for us. Again, it's important for us to recognize airway obstructions. So those airway obstructions are including recognizing a stridor, recognizing a wheeze. So if we're going to talk about some of them a little bit later, and we've got some videos of stridor and we've got videos of a wheeze for you to recognize. So if you recognize it, again, we need to upgrade the response to you. What else is really important is that we look, listen and feel for breathing. So it's all going back to basics. We're doing a respiratory rate and we're looking, listening, feeling for breathing. Because the baby's chest or the child's chest is still developing, it is still growing, it is still flexible. So paradoxal chest movements is more likely in a child. So the chest could be moving, but they may not be breathing and they may not be moving air in and out. So if you see the child's chest going up and down, doesn't always mean they are breathing effectively or breathing at all. So please always go down, look, listen and feel for air. Make sure you can feel air moving in and out and you can hear it. And recognize any paradoxal chest movement, because everything is still very flexible in a child. So they are the key airway problems or considerations that we need to consider. Smaller face, they've got a compressible lower floor of their mouth, so just watch where your fingers are going. Mass sizing is really important because we don't want that build up of pressure under the eye socket causing reflex bradycardia. It is very unlikely, but it is a possibility. So either flip the mask round if it is too big for the child and have the pointy bit underneath, pushing air down, not into the eyes, if you have to. Let's consider airway and identifying airway problems early on. So looking for the stridor, looking for the wheeze, identifying objects, because if we go past the choking protocol, it is very unlikely that we're going to be able to push it down with a strong ventilation into that right bronchi because of it being narrower and shorter. And then finally, please do not forget to look, listen and feel for patients breathing, because of the flexibility of the chests and the paradoxal chest movements. Cool. So any questions on airway considerations? So we're going to talk about the three big ones. So airway and breathing next. Yeah, we'll talk about BVMs now. Cool. So smaller lungs means a reduced reserve volume. So we're going to talk about ventilations. Again, this is really important when ventilations. We'll go through them all. Weak accessory muscles and breathing relies on the diaphragm. So, all right, let's start here then. So the lungs are smaller and they've got a less reserve on their volume. So again, referring to an adult or comparing with an adult, we just squeeze probably half the bag, if that, to inflate the chest and have adequate ventilation of your child, of your adult, because they've got this reserve volume in their lungs and in their body. With a child, they don't. Their lungs are still growing, they're still developing. So when we're ventilating child, it is really important that we identify the rise and fall of the chest. Unlike an adult, we're just going to do a half. With a child, we have to identify the rise and fall. When we see it rise, we need to stop and do our 1 second. So when we're ventilating, we're looking at the chest. When it goes up, we're happy. It is unlikely to cause bowel trauma to the chest with the new BVMs because the BVMs have a blow-off valve. So if you're putting too much pressure, you'll hear a blow-off noise coming out. And that just shows you're trying to inflate those lungs a little bit too much. So when we're identifying and when we're doing a ventilations for a child, ideally two-person technique is going to be ideal because of that airway problem. If you can't, then we just have to consider airway, but also consider how much of the ventilations you are doing, identifying the rise and fall. Once you've got rise, then we go on to the next ventilation. If you hear the blow-off valve, please stop and do our kind of 1 second cycle of our ventilations. Weak accessory muscles then. So again, everything's flexible. So they've got weak accessory muscles, and especially in infants. So I think it's under 5 we're going to talk about. Yeah, so under 5, everything is weak. So it's very unlikely they're going to be using their intercostal accessory muscles. When they're over 5, it is developed, and then you'll see that a little bit more, and that's quite a bad sign. But in infants and in babies, they rely on their diaphragm. So when we're checking the respiratory rate, you're looking at the stomach mainly doing all their work. And you may see their stomach sucking in now and again when they are really struggling. Other accessory muscles that they may use, especially in infants, is head bobbing. We've got a good video of head bobbing. So when we're talking about an infant, they are using the diaphragm to do all the work, and they haven't got any, the intercostal muscles are still very weak, so they're going to be using the head to do a lot of the work for them. Over 5s, they've got the development, their muscles are growing a little bit more, so they will start using the intercostal muscles. So if you identify a child over 5 using intercostal muscles recession, then that is a red flag sign for us again. So if those little muscles between the ribs are sucking in with each breath, then that's a bad sign, especially over 5. So we need to identify that and red flag that. Children have a high baseline metabolical rate. So again, children are growing, they're using so much energy to grow and develop. So their kind of metabolical rate, ours is down here, we're okay. When we get unwell, it goes up a little bit. But for children, they're working at max, they're growing, they're developing. So when a child gets unwell, they've got very little capacity to do any more. So they will compensate because they've got such a high metabolical rate. But you may have heard when children can compensate, and then they kind of fall off a cliff and they go down really rapidly, because that is they've ran out of energy. They're really high baseline metabolical rate. When they're unwell, they've got no more capacity, so they're running at max now until they get too tired, and then they fall off that cliff and they deteriorate rapidly. And that does affect us in the circulatory system as well, and we'll talk about that again with blood pressures. So very often the increase in a respiratory rate is the first sign of illness. So again, I've said it before, it's really important that you take a respiratory rate on a child, and we're counting for the full 60 seconds. So we're not doing 30 and doubling or anything like that. We're going to count for the full minute. It is the first sign of them becoming unwell, first sign of dehydration, first sign of meningitis is their respiratory rate to go up. Looking for those abnormal sounds again. So we're looking at stridor, which we talked about in the airway, that high pitch. We're looking at grunting sounds. We're looking at wheezing. We're looking at secretions, that kind of chesty sound to a child. So again, if we're hearing it, then we need to identify it, and we need to be able to record and pass that information on if we need to upgrade the call. Accessory muscles then that we kind of talked about, recession, particularly bad in over 5s, it's a more worrying sign, because under 5s, unlikely because their chest is still developing, it is still very weak and flexible. So over 5s, if we see it, if we see their chest sucking in, those little ribs, the muscles between the ribs sucking in, it is a worrying sign. It's a red flag for us, and we need to identify it and be able to upgrade the call and tell CCC clinicians in control. Nasal flaring then can occur in younger children. This will come along with the head bobbing. You probably get nasal flaring a little bit sooner than head bobbing. So if they haven't, under 5s, they haven't got the accessory muscles as such, then you'll see the nasal flaring. And we have got a video of that as well that you'll see. Accessory muscles, head bobbing. I've talked about head bobbing already. So yeah, breathing, really important that one, we identify the sounds. We identify they are breathing, so we look, listen, feel. We check their respiratory rate. Then we're looking for those signs. We're looking for the abnormal sounds, stridor, grunting, wheezing. We're looking for their chest. So we're looking for accessory muscles, recession. We're looking for nasal flaring in younger children and head bobbing in younger children, normally infants. So if we identify any of those signs, then again, we need to be upgrading this response and talking to our clinical desk and the clinicians in control. So yeah, that is breathing. Remember, any of this, we need to be having your child down to a nappy so we can have a look at their chest. Adults can tell us, children can't. We need to be able to have a look at their chest and look at their effort of breathing. Everyone happy with breathing? Oh, circulation then. So this is where we talked about a catastrophic hemorrhage in a child is really significant. So a newborn will have a blood volume of around 240 mils, which is 2/3 of a can of Coke. That goes up to the age of puberty, so it'll be 80 mils per kilogram. And then when we get to an adult, it's 70 mils per kilogram. So why we tell you that and why that is significant is your child will get dehydrated a lot sooner than an adult would. So one of those big questions that we hear, especially from paediatricians and hospitals, GPs, has the baby had any wet nappies? If they haven't had any wet nappies, then most likely they are going to be dehydrated. So dehydration is a big problem in children, and one of the things that we kind of need to identify early. Increasing heart rate is the only way of increasing blood pressure. So unlike with an adult, raising legs works really well for an adult. In children, it wouldn't work. So the only way of doing it is raising the heart rate of it. Children will compensate really well, and this is where I talked about the high metabolical rate. Everything's working really well. They'll get to the point where they're getting unwell, they look okay, they're off a cliff, then it is a battle to help them up the hill again. So really important that we identify any kind of circulatory problems, and we'll talk about how. Blood pressure is very little, to be honest, in a child. We would, and I probably would only do a blood pressure in a very significantly unwell child, because it doesn't give us a lot of information. What gives us a lot of information is if that child is pale and mottled skin. So blood pressure is very literally kind of used in the pre-hospital environment. Capillary bed refill is a lot better. Bradycardia is a serious sign, so often is the main reason for us to start CPR if they have got bradycardia. Cap refill then, really useful. Like I've said, if you can't get a pulse rate in a child, it's really hard. If you can't find a radial, often you have to go straight for the brachial. And again, really hard to count because it's normally a lot faster in a child to be able to count that quickly. So if you can't, then you can rely on cap refill. So cap refill is looking at how long it takes for the skin to go from white to pink. So we do it centrally in a child. So you can do it on yourself if you wanted. All you're going to do is push down on your skin. You can do it on your forehead. Push down for 5 seconds. Come away. It is white. And then it should come back within 2 seconds. So if you do it on yourselves, hopefully you'll do it and the pinkness comes back within 2 seconds. If it takes 2 to 4 seconds, that isn't great. If it takes more than 5, that is really bad. And normally will come in line with bradycardia if it is that slow at coming back. Perfusion isn't working if it takes more than 5 seconds for it to come back. So it should be less than 2. 2 to 4 is not great, but anything more than 5 is really bad. And we need to be able to identify those patients. Skin temperature and colour, again, just back to basics with children. So we've talked about colour, we've talked about pale and mottled skin, and we've talked about the temperature, so the cooling of the shell. So is the hands and feet a lot cooler than the central? If it is, they are early warning signs for us. So if the feet's a lot cooler, then what we're worried about is dehydration. We're worried about sepsis. We're worried about meningitis. Done. So that is circulation. So they've got a little blood volume. It will increase as they get older. The only way of us increasing their blood pressure is by increasing the heart rate. Child will compensate really well because of their high metabolical rate, but it will get to a point where they run out of energy and they fall off that cliff. We don't want to get there. We need to identify it earlier. How we identify it is with circulation. We're looking at the colour of the child. We're looking for pale. We're looking for mottled skin. If we've identified that, we're also looking at the temperature of the child. Are the hands and feet cooler compared to the central? We're looking at cap refill. Should come back within 2. If it doesn't, then it's bad. 5 and more is very bad. So we need to identify it, and by identifying it, then we can identify and go down the line of sepsis. We're going down the line of dehydration, and that is really common because of the little blood volume that they do have when they are born. Awesome. So BAME. Yeah, so BAME. So yes, easy to find in white colour, but any BAME kind of patient, what we're looking for, easiest way to describe it is looking at the pink areas. So you're looking at the lips. So pull their lip down. That should be pink. If it isn't, if it's pale, then that's what we're looking for. We can look under the eyelids. Again, the eyelids should be really pink. Looking at the hands, their hands are normally really pink because they're using it a lot and it's kind of well. So it is harder to find. I get that, Neil, but we are looking for the pink areas. So pull the lips down, have a look at their eyes, have a look at their hands. Mottled skin you still can get, but again, it's really hard to find. So if you look at the pink areas, is a good way of doing it. And ask the family or parents of the child, do they look normal? Do they look pale? What's their colour like? Awesome. So what we're going to do now is look at some videos. So first thing we're going to look at is Croup and Stridor. So what you can see there is stomach's doing a lot, the diaphragm's doing a lot of work for it. We're looking at a little bit of accessory muscle use down the bottom. There is a bit of sternal recession as well. The sternum is sucking in. And that child looks really tired as well, which isn't a great sign. So a tiny little bit of tracheal tug as well. So if you down look at the neck area, you can see that sucking in a little bit, and you'll find that in children quite often. Hopefully you can hear that stridor. So, child looks really unwell, looks really tired, exhausted. It's using accessory muscles. You can see the chest moving. You can see the stomach doing all the work. There's a little bit of tracheal tug, and you can hear that stridor. So that's in a toddler kind of age group, and stridor is something that we can kind of identify in most age groups, but normally in the toddlers up is the commoner ones. So we're going to look at a very younger child now, an infant. So this is a good example of head bobbing. So with the toddler, they had some development of their muscles. So they were using a little bit of accessory muscles. They're using sternum, trachea. With the infant, a little bit harder. They can't. They're all floppy. They're still growing. So that head bobbing you would have seen, and you would have seen some nasal flaring. But the child has got oxygen on, so you probably you won't see it in this video. But if you see head bobbing, that is critical. That is a really bad sign. If you see head bobbing, they are really struggling. That child is struggling with oxygen on. So if you see head bobbing, it is definitely a call to a clinician in control to upgrade your response. Next one is an older child.
Have a look at chest of this child and you can see intercostal retractions, quite prominent. Suprasternal retractions are also nicely visible. Now look at the face of the child to see flaring of Alanesi, and the child looks severely
Cool. So that is coming up
distressed.
to an older child, a teenager-ish, 11, 12 maybe. So yes, he was very skinny, but you could see those accessory muscles sucking in. And you can see this here as well, sucking in up here. And they look really poorly. They look really tired. They're at that metabolical rate. They're pushing it. They're getting to that exhausted stage, and they're going to deteriorate from here on. And then finally, we're looking at stridor. Cool. So he is sat up. So he's still got stridor when he's sat up, and it's more of a higher pitch than anything. So hopefully we'll be able to recognise that. So what we're going to go on to is some assessment tools and some frameworks that you can use. These are all very similar. So we'll kind of go through them. With paediatrics, it is a standoff assessment. So it's really hard to assess a child. So it's sometimes a standoff and just looking is enough because it's all going back to the basics. And we can't always talk to a child. So this triangle is really good. So hopefully you've seen it before. We're looking at parents, we're looking at work of breathing, and we're looking at circulation. And we've talked about all of this already. So appearance is probably the newest, and what we look at is tickles. So we look at the tone, interaction, consolability, I can't speak to this evening, and we're looking at the look and the speech of the child. So we're excuse me, we're looking at the tone. So this is the muscle tone. If we move their limbs, they should have some tone to it. If it is just a floppy limb, then we need to identify that. Interactions in a child. Any child should be wary of a stranger. So if you walk in the room with your PPE on, different uniform, they should identify you straight away and they should be looking at you at least or crying. If you don't get any interaction at all, then that is a red flag for us as well. So reduce interaction from that child. Controllability. So controllability, if a child is unwell, if one of my kids fall over, if they hurt themselves, they come running to me straight away for a cuddle and a cutch, and then they're all better. If they're unwell, they just want a cutch all the time to make them feel better. and they'll stop crying and they'll be happy. If that doesn't work, and then that is what we're concerned about. So if the parent can't console their child, which they would normally, then that is another red flag for us. We're looking at the gaze. So if they're just looking through you, then again, this should be a red flag for us. And then the speech and cry. So the parents will recognize a different speech and cry to their child. So I know when my kids are fighting each other compared to when one of them hurts themselves. So they've got that different cry. So a lot of this is a standoff assessment. We can look at the child and we can ask those parents. Then we're looking at work of breathing, and we've talked about this. We're looking at those abnormal sounds. So the stridor, the wheeze and the grunting. We're looking at the positioning of the child. We're looking at recession. We're looking at the use of accessory muscles. We're looking at nasal flaring, gasping, apneic episodes when they're holding their breath. And then circulation and to the skin. So we're looking for pallor. We're looking for mottled skin. We're looking for cyanosis. So really simple. We can do it off a standoff, and we can look at tickles. We can look at the colour, and we're looking at the work of breathing. So the Pediatric triangle doesn't need you actually to touch the patient yet. So you don't have to do your respiratory rate and pulse rate. By just looking at the patient, we can have some sort of idea what is going on with them. Other way then is tickles. Again, it is just looking at the parent side of it. So this is from the NICE guidelines. So the Pediatric triangle is really good, but it doesn't allow us to know what is good and what isn't good. So you can't read this. So I would recommend to you just do a search and do some own research onto this. Is the NICE traffic light system for pediatrics. So what it does, it goes through the tone, interactivity, controllability, look, glaze, speech and cry, but it will give you a low risk, a medium risk and a high risk. So if I was to take activity, so if your patient's responding normally, social, their normal cry, there's no concerns, then that is a green. If they're not responding normally, so the parents say they're not responding normally to social cues, so you walk in the room and they're not bothered, they're just identifying something else, they're not smiling, they only wake up after prolonged stimulation, so it takes them a while to wake up, and a decreased activity, then this is a medium risk for us. And then no response at all, not waking up, continuous crying and no controllability from the parents, then this is a high risk for us. So again, have a look at it. It will make your tickles a little bit easier to understand in your pediatric assessment, but have a look at that. POPs then, so we've talked about NOOS in our CPD, and POPs is the child version of it. So POP stands for Pediatric Observation Priority Scoring. So there are quite a few out there. You've got PEWS, which is the NOOS for pediatrics that are used in hospital. PEWS doesn't really work well for us in the pre-hospital setting. So in the pre-hospital setting, we use POPs, but you won't find POPs in a hospital because they use PEWS, which is just exactly the same as NOOS, just for children. But we wouldn't be doing blood pressures and stuff and that with a child pre-hospitally. And this has a little bit more and nicer for us. So looking at the top stage is your child can score in multiple of these. So we're looking at the SATs. 95 above were happy, and then they start scoring either way. We're looking at breathing, and this is where they can score more than one. So if your patient's got stridor and mild recession, so they will get a score of 3 in this section. Then you would look at the AVPU, alert, Your gut feeling is a really nice one. You're there in front of the patient. Do they look unwell? Do they look well? So you can score your own gut feeling on it. And then again, they can score multiple here. So if they were prem and they've got a heart condition, they would score a 3 out of there. So potentially they would score 3, 6, we'll say 7, 8 in the first section. So you'll find they can get really high pop scores really easy. And it is the same ranking as your news score. 0 to 1, we're happy. 2 to 3, we're concerned. 4 to 5, they've got a rapid risk of deteriorating, and 8 and above, then we're worried about critical illness. So that's the top one. They can score multiple in those. And then the bottom phase of it is you pick one of them compared to the age group. So if it's a 1-year-old, we're just looking at this section. So we're looking at pulse, respiratory rate, and temperature. So I know as CFRs, you can't do temperatures at the moment on children, but that may change in the future. This is a slow rollout of observations, but you can do pulse rate and you can do respiratory rate. So you'll probably get a really high pop score without having the temperature in it. So you can still use it, but you just can't do a temperature at the moment with it. So that's POPs. Have a look at it. It is useful scoring matrix for you, and there is a app available for it as well. You can download your news and your POPs, and it will be available on your ePCR. Can we use the temp of the parent? Yes, you can. Yeah, if the parent can take a temp, then yeah. It's just protocols at the moment that we can't allow you to do it, but it will happen. Then we talk about respiratory rates. They do change. So adult patients and 12 and above, from puberty onwards, they're saying 12 to 20. As long as we recognise it is faster. Have it printed out, or we've all got smartphones. All your NMAs are on smartphones. So you can just Google what a normal breathing rate is for a 1-year-old if you're going to a 1-year-old patient. Same with a respiratory rate and a heart rate. 10 and above, we're saying 60 to 100, then it gets faster. Same thing, if you're using your NMA, just Google what a normal heart rate is for a 3-month-old. It's the kind of easiest. Something to note then is a heart rate will drop in a newborn. So that is quite normal for them. So that's why the range is 85 to 205. So you may think, why is it 100 to 180? Why is it dropped to 85? Because it is normal for their heart rate to drop when they are sleeping. We're going to look at some common conditions. So could you name some common conditions that you may come across in a child? Oh, you've all said asthma. All right, cool. Yeah, asthma. Good. So asthma is a challenge of itself. We'll probably do one of these webinars just on asthma, but we won't talk about that tonight. Febrile convulsion, we've kind of talked about on our CPD this year. Croup is a really big one. We'll talk about croup. Bronchitis, yeah, good. Diabetes, burns, meningitis, yeah, we'll talk about meningitis tonight. Choking, good. Anaphylaxis, hypo, shock. Cool. Okay. So what we're going to do is talk about 3 common ones. So we're going to talk about croup, we're going to talk about meningitis and epiglottitis, because they are quite the key life-threatening things that we may come across and we need to identify quite soon. So pediatric emergencies. Meningitis then. So what is meningitis? So basically, it is the inflammation of the layers of the brain that protects the brain. So we're talking about the meningendi, the three layers. So I don't know if it will work. So we've got the skin, we've got the skull. Then we're looking at the three protective layers. So we're looking at the dural matter, arachnoid matter, and the pia matter. So this is the inflammation layers that protects our brain. So they're really important. And this is where if we get a meningitis, and there's two forms, we've got viral meningitis and we've got bacterial meningitis. So the dural matter and pia matter, what we're worried about is the arachnoid matter. So this section here. So in this section, it thrives, it grows. So if we get an infection, if we get a bacterial or viral infection in this section, then it develops, it grows, it increases rapidly. So that's why it's so of a life-threatening condition. So other bad thing is once it's in this arachnoid matter, we've got our spinal fluid developing in this section, and this is where the spinal fluid kind of flows. So we can get a bacterial infection throughout our body rapidly now. So meningitis is the inflammation of these three layers. When it gets into the arachnoid matter, it gets into our spinal fluid. Spinal fluid is our motorway system to the rest of our body and the rest of our nervous system. So really important that we identify it, and this is why it is life-threatening, because it can spread really quickly. Can be viral and bacteria. Bacterial is the worst type, and then viral, they're both really bad, but viral is treated a little bit easier. So I have been really lucky or unlucky to have both. I had bacterial meningitis when I was younger, and then I had viral meningitis about 4 years ago. So yeah, and we'll talk about some of the symptoms and the common groups that do get meningitis. So like I said, it's caused about those inflammation of those protective layers. As soon as it gets in that arachnoid, it gets into the spinal fluid and spreads, and that's when it becomes life-threatening, and it can kill within hours. It can affect anyone, but it's more common in younger people. So the common age groups are primary school, so the first year of primary school, and the first year of university. And that is down to the increase of social interaction. Can be bacterial, can be viral, and you can get it even if you're vaccinated. So no vaccine is 100%. Yeah, cool. So that is meningitis. Symptoms of it then. So we can have a severe headache, we can have fever, vomiting, stiff neck, dislike to bright light or photophobia, confusion, delirium, fast breathing rate, pains in the muscles and joints, cold hands, feet, shivering, rashes, very sleepy, lethargic, seizures very late on, and then pale or mottled skin. So it can be quite hard to identify. So in a younger child, in the primary age group, hopefully we'll be able to recognise it, because hopefully we can question that child and we can find out a head injury or headaches, photophobia, stiff necks. They can tell us that. Infants, it's a lot harder, but like I said, we need to identify a respiratory rate, high respiratory rate. We're looking for pale or mottled skin. We're looking for cold hands, cold feet. So these are all signs that we've talked about already in the paediatric assessment. And then it gets even more vague when they get to university stage. So the first year of university, everyone's got a headache, everyone's vomiting, everyone's got a stiff neck, everyone's got photophobia, everyone's got confusion, pain, sleepiness, and pale, because they are all on it in Freshers Week, and it's all very similar signs to a hangover. So yeah, it is very hard to identify. So that's why we should stick to our paediatric assessment. If you're doing your paediatric triangle, you will identify a fast breathing rate, you will identify pale mottled skin, you will identify cold hands and feet. Cool. So yeah, it is very vague, but you can do it. Rashes then is really rare. So anyone that thinks of meningitis, they think about this meningitis rash. It's only present in 40% of the cases, and it's a very late stage in it. It is when they've got to septicemia, sepsis. So the infection's taken hold, it's gone into the arachnoid, down in the spinal fluid and spread. So what the non-blanching rash is basically is looking at this rash, you would put a glass over it, roll the glass over it, and it does not disappear. If you had a heat rash or anything, it would do the same as you would do if you're doing a cap refill. It will go white and disappear and then come back once you've kind of rolled over it. But with a non-blanching rash, it would not go away with that glass test. But remember, only 40% of cases have it, and it's a very late stage, so we may not see it in the pre-hospital environment. So that is meningitis, really quick. But if we do a proper paediatric assessment, we should be able to identify a sick child and point us down this line. Then we talk about croup and epiglottitis. So which is the most life-threatening then, croup or epiglottitis, would you say? Put E or C in the chat. Very good. Good. So yeah, everyone's saying epiglottitis. Excellent. Good. You would be right. So let's talk about it then. Croup. Croup is the swelling around the voice box. So it doesn't always formally have an airway obstruction. So what we're looking for is this section here. So these two black lines are our vocal cords. So we've got a little bit of a swelling here and here of those vocal cords and of our voice box. So that's where you get that iconic seal bark cough from, because it's affecting those vocal cords. Anyone with croup will have that hoarse voice. Again, that is because the voice box is affected. So those identifying signs is the seal barking cough and the hoarse voice, that is down to the voice box and those vocal cords being affected by edema and swelling. When we're talking about epiglottitis, this is life-threatening, and that is the swelling of the epiglottis. And we know the epiglottis is that flap that allows us to breathe, allows us to drink, allows us to swallow. So if we've got swelling and inflammation around the epiglottitis, it is very easy and very common for it to go into spasm and for the epiglottis to close, causing a formal airway obstruction and a life-threatening one at it. So they would got no air through if that epiglottitis spasms and closes. There's no other real way of opening that up. So really important that we kind of identify that. And they're the two differences. Epiglottitis is affecting the epiglottis. That little flap that goes over allows us to breathe, drink, swallow. Croup is the vocal cords and the voice box, basically, edema around that. How we recognise it then? So looking at croup first. So a croup person will look well. They'll look quite well. Onset can be quite slow. They'll have a moderate fever. They may have some stridor, but it'll be very mild to moderate. But they will have that barking, seal-like cough, and they'll have that hoarseness of their voice. And they'll be able to swallow because it's lower below the epiglottitis that's affected. So that is croup. Hopefully we can recognise that quite easily. Epiglottitis, then, your patient is going to look toxic, really unwell. It can be a sudden onset. They're going to have a high fever of 38.5 and above, the textbooks say. They will have a stridor, which will be moderate to severe. They won't or have an absent cough. They won't be able to speak. And the biggest sign is that saliva secretions. So they won't be able to swallow and they'll be drooling. Is the kind of the big signs of it. So big stridor and unable to speak, unable to swallow, they'll be drooling with saliva. Your treatment of it is just management of that patient's airway. So any child with a significant illness or injury will get 100% oxygen, and these patients would. And you need to update clinical desk so we can get priority backup to you. This year is going to be really challenging, so talking to the clinical desk is going to be really important for us to categorize the call correctly for you and getting the correct backup. Croup cough is the only good cough in 2021. Yeah, I like that. Cool. Cool. Excellent. So any questions from anyone? So Pediatrics is all about going back to the basics and just looking at the patient and identifying those signs. No worries. Ben, have you got a question?
Yeah, well, it's just a quick one. The Welsh safeguarding app, just to share. So I work in social services. I'm an occupational therapist, and we get lots of training on safeguarding, as you would imagine. But the All Welsh safeguarding app, it's just full, crammed, absolute stuff full of information. It's really easy to navigate. Some of it is probably beyond what we'll need as a CFR because it talks about the reporting procedure. So I'm guessing for us, it's either in our crew handover or it's back to clinical desk. Any concerns that we have, isn't it? Basically, we're passing. We're if you like, we're because I think the big sort of takeaway for me out of safeguard training is it's everybody's responsibility. So, but the way we can discharge our duties is through reporting it up as CFRs, isn't it, to the crews? But the app is absolutely fantastic. You know, you can get bogged down in a lot of the statutes and stuff, but if you're just looking for information on the different types of harm to kids and things like that, it breaks everything down. There's loads of really, really useful stuff on there. If you're looking for it on the app stores and stuff, it's the map of Wales in green. And I think it's Welsh Safeguarding Wales app. So it was just to share that really, but you might look at it and think, well, there's a lot of stuff here. It's very procedural, but so section 1, so for instance, section 1 on children and young people at risk of harm, it goes through basically the principles of safeguarding, and it goes through all the key definitions relevant to safeguarding of children. It's really handy, and it's got adults on there as well, so it's a nice one to have on your phone if you got it. Yeah, thanks whoever's got it up on their phone. You did a much better job than I did. Thanks, John. Awesome. That was all. I just wanted to share that. So
yeah, no, very good. Really Thank you, Ben. We'll probably try and push that out to the NMAs. We've got the ability to do that, so that's probably a very good app to have on our NMA devices. So yeah, I'll take that to our meeting and try and arrange that. Awesome, very good. So very quickly then, let's finish off. So hopefully you found this session beneficial. We talked about the primary survey and identifying and those considerations that we should have in pediatrics, and identifying those safeguarding as well as a part of that primary survey. We talked about some differences with pediatrics when we talked about the big A, B, C problems. A little bit of research for you. Have a look at the pediatric triangle, have a look at POP scoring, have a look at the new, the NICE guidelines, the tickles there. And we talked about some of those common illnesses. So we've talked about meningitis and we've talked about croup and epiglottitis as a bit of a recap. So hopefully you've all found it beneficial. So our next session is going to be Wednesday, the 5th of Jan. Don't know what the topic is yet, but that will be one of the other trainers, and we'll get that topic out. If you've got a topic you would like to cover, again, like I said, please email the shared inbox. Finish off the session with our wellbeing checklist. So please reflect on something that went well today. Recognise something that was difficult and learn from it. Check in with colleagues around you. It can be friends, family, it can be other volunteers. Reflect on a moment that you made a difference to a person and be proud of it, and be proud to volunteer as a CFR and for the Welsh Ambulance Service. You guys are doing an amazing thing, especially at such a challenging time. Talk about challenging time, please ask yourself, are you okay? If the answer is no, or I don't really know, then please reach out. Please reach out to us and we will support you. There's so much support networks available to you, and we are here for you. And then finally, hopefully you are home, but go home, rest, restore, do something that you enjoy. It's all about work-life balance, and never feel pressured into responding. If you can't, you can't. But we just thank you for any support that you give us in the coming months.